السلام عليكم شباب. اليوم إن شاء الله راح نكمل موضوعنا. اليوم متعلق بالدنتوفيشال انفكشن. اليوم حتكون شرح المحاضرتين، المحاضرة السابقة اللي هي Principles of Management، والمحاضرة الجديدة اللي هي Route of Spread. Okay, so by the end of this lecture, I'm expecting from you guys to understand the principles required to manage the dentofacial infection, like how we manage it, the best way and the easiest way, and when to refer the patients to the oral and maxillofacial surgeon, and know how and what to prescribe for the medication, and let's say not complete principles of surgical treatment, but I'll give you the headlines, how to treat the minor dentofacial infection, and finally what are the possible routes for spread. So here, this algorithm is show you the way you manage the dentofacial infection. So first of all, as I always say, we have to take the history from the patient. History and physical examinations. Like I need to ask the patient, what brought you to my clinic today? What's your chief complaint, or what's your major concern? Why you are here at my clinic? Just ask him in the normal way. Okay, then write the answer of the patient exactly what he or she said to you. Never change it. Like it should be and must be the patient's own word. Then after taking the history, give me the chief complaint. I'm gonna ask him, when was the first time you noticed? Let's say the patient, oh, I have pain and abscess on the right side of my face. Then you're gonna ask him, when was the first time you felt that pain? When was the first time you saw that swelling? And ask him if the swelling is getting increase in its size or decrease or stay still the same size. Or what's the worst time for the pain and the abscess at the day? All of these questions, we should write down the answers for it before proceed with any further treatment. Then do the physical examination. Physical examination, in this case, for a dentogenic infection, the most important part of the physical examination is to take the vital signs. The vital signs of the patients includes three things: the body temperature, the respiratory rate, and the heart rate. So we're going to discuss that in details, but let's give you a quick brief about it. The body temperature, the normal body temperature is about 37.2 Celsius. So if the patient has 38.3 or 38.5 degrees Celsius of the body temperature, this means the patient has a fever. Fever بالعربي يعني سخونة خلينا نقول. This is a sign for something wrong going on to the patient's body. The second thing is the respiratory rate. The normal respiration rate is from 12 to 16 breaths per minute. So if the respiratory rate exceeds 18 breaths per minute, this is what we call it a tachypnea. So this is something wrong, like maybe the infection spread to almost all over the body and called some sort of severe bacteremia. Besides, the increased body temperature, which is the fever, will also lead to increase in the respiration rate. And finally, the heart rate, or the tachycardia, and again, it is an alarming indicator of something wrong happening with the dentofacial infection. So let's say we check that, do the physical examination, we check the vital signs, then we're gonna go to check the patient's extraorally, and by checking the site of the swelling, the site of the pain, any lymph node involvement, what is the texture of the swelling, and we're gonna have details about what's the difference between them. And then we go to the intraoral examination, checking for any caries, periodontitis, pericoronitis, and then take the x-ray. Combining all of these things together, then we're going to move to, we're going to achieve the right way to assess the severity of the abscess. Then we're going to take a history of evaluate the host defense medical comorbidities and condition of the patient that could affect the patient's ability to withstand this infection. Let's say you see that the patient has a severe condition, then you're going to refer it to the oral and maxillofacial surgeon, or if it's you can manage it or it's outpatient, then you're going to go to determine in which stage is that the infection. Is it still in inoculation stage? And as you remember, it's going to be started from day 0 to day 3, and then there's going to be a mild edema with mild pain, so we can manage it either by extract the tooth, do endodontic treatment, and do scaling or debridement. If it's cellulitis or abscess, we have to do the incision and drainage, I&D, and remove dental cause plus to this one. So what's the make the difference between this point and this point? Here we don't have abscess, here we do have abscess. So in addition to extraction or root canal or debridement, we have to do incision and drainage. And the rationale behind that when I do drainage, then I will reduce the amount of bacteria available at the infection site, and I will reduce the pressure on the tissues at the infection site, then will lead to reduce the possibility of spread to the deeper spaces. And finally, reducing the pressure will also increase the blood flow rate at the area of infection, which gives a good chance to wash out activity of the blood to the area. Then once we remove the major cause of the infection and do the incision and drainage, then we will give the antibiotics and analgesics, painkiller, plus give a patient to take care of his food and hydration and nutrition. Then we have to follow up for 72 hours. We have to see the reduction, the body temperature, and the swelling size, and the patient will be able to perform the normal daily activities, which is good. But anything else, we have to refer it to the hospital. So let's go back to this for the principle number 1 for the dentofacial management is determine the severity. How we can determine the severity is by taking the history. As I said, try the chief complaint, CC. When and how long you have this chief complaint. Is it the swelling getting any bigger, wax and waned؟ يعني بالعربي خلينا نقول الحجم يصغر ويكبر أو يروح ويجي أو ثابت. Any difficulties in the breathing, swallowing, limited mouth opening. These are, and again, is the red alarming symptoms. If the patient tell you that I can't breathe, I have difficulty in swallowing or limited mouth opening, then you have to think seriously there's something bad is happening. And check for the cardinal signs of infection. What are the cardinal signs of infection? I think this picture is going to give you a good clue and good memorization for the cardinal signs of inflammation. Heat, like the site of infection is going to be hyperthermic. شوية احنا نقول مسخن سخونة، اوكي، يكون حار. المنطقة الخاصة اللي بيها infection يلزمها المريض اللي عنده abscess لو swelling بأي جهة من جهة الفيس، من يحط عليها أو أنت تحط يدك عليها تلقاها حارة مقارنة بالمنطقة بسطحها. So هذا heat. Okay, then we have a redness، تكون المنطقة حمراء، حالة cellulitis, swelling, and pain, and loss of function. زين loss of function شلون تكون عندنا من الأورال كافيتي اللي هي خلينا نقول limited mouth opening أو difficulty in breathing or difficulty in swallowing. So then as we said, the first principle is to determine the severity. We take the history. Now we're going to do the physical examination, which is include the vital signs, extraoral examination, intraoral examination, and radiographs. And we're going to go in further details. As I mentioned before, we have to take the body temperature, respiratory rate, and pulse rate, and we consider the patient is in fever when the body temperature is going to be 38.3 Celsius or more. and there's a tachycardia, tachypnea. Okay, and when we have these things, I prefer to refer it to the hospital immediately. Don't try to play with this patient. Just give him medication and tell him to go to the hospital as soon as possible, unless you're a good practiced oral surgeon, so you can manage the abscess or the cause of infection. Then we check for the extraoral examination. We need to check the site of the swelling, any asymmetry of the face, any fistulas. Some people, they do have a fistulas on the skin. Then check the location. It's going to be on the right side, on the left side, or on the top of the bottom of the face, or maybe a half face swelling. Color, any texture for it could be red. The swelling consistency, it is easy to assess the stage of infection. The swelling of a consistency we have, it could be edema, which is indicate the inoculation period of the infection, or it could be cellulitis, and finally the swelling. The most dangerous one is the cellulitis. Cellulitis is going to be diffuse redness with diffuse swelling covered with the red skin over the affected area, and the texture or the consistency of this swelling is going to be almost too hard, not 100% hard, like يشبه لكم إياها مثل ما واحد يضغط على بوتيتا مسلوقة. هذا راح يكون هو السيلولايتس. الباس بالضبط مثل ما تضغط على بالون filled with water، نفاخة متروسة مي. الأديمة شيء كلش قليل، يعني ما تشوفه بالعين، يعني خلينا نقول السوالينج مالتها كلش قليل، وتكون الكونسستنسي مالتها شيء بين الابسس وبين السيلولايتس. بس اللي تميزها النقطة الثانية اللي تميز الابسس بها عن السيلولايتس إنه the abscess has a confined border and does not extend over the broad area, while the cellulitis doesn't have any border and extend over a large area of the face. Then we check the amount of mouth opening. If we have a limited mouth opening, we have trismus, we have pain when you open the mouth, that's again an indication of some infection involvement. Then we're going to go to the intraoral examination, check the periodontal condition, caries, oral hygiene, check for any intraoral swellings, any intraoral fistula, and again, always give the location, give the color, and the swelling consistency, and any pus discharge. So, principle number 2, then we assess the severity. So, from the above, the previously mentioned criteria, if it's a severe case, then you have to refer it to the hospital or oral maxillofacial surgeon. If you can manage that, you're good to do so. But before to reach the final assessment, we have to check the patient defense mechanism. What do we mean? If the patient is the patient defense mechanism compromised, like maybe the patient has some medical conditions will affect the ability to fight the bacterial infection. Could be poorly controlled diabetes, alcoholism, or have a malnutrition or end-stage renal failure. These called uncontrolled metabolic diseases. Or some patients have an immune system suppressing diseases like HIV, lymphomas and leukemias, other malignancies, and congenital and acquired immunologic diseases. So these also we need to keep it in mind when we take the history. نسأل المريض عن صحته العامة، شو أمراض عنده لازم يحكي لك إياها حتى تعرف شلون تتعامل وياه. And finally, if the patient taking any immunosuppressive therapies like cancer chemotherapy, corticosteroid, or organ transplantation، إذا ياخذون كيموثيرابي أو عملية زرع الكلى ياخذون immunosuppressive medication اللي almost corticosteroids حتى يقلل من مناعة الجسم، حتى الجسم لا يرفض الأورجان الجديد. So, principle 3, when to refer to the oral maxillofacial surgeon. So these are the criteria you need to keep in mind. When you notice it on the patients, you have to refer it to the oral maxillofacial surgeon. First of all, difficulty of breathing, difficulty swallowing, dehydration، يجيك المريض نقول ريقه ناشف، حلقه يابس. Moderate to severe trismus، like the limited mouth opening less than 20 millimeter. The normal mouth opening, it should be between 35 to 55 millimeter. So if it's anything below 20 millimeter, then it's going to be means the patient have something wrong with the masseter muscle or the TMJ or the mouth. Swelling extending beyond the alveolar process, which means the involvement of facial spaces or deep facial spaces. Elevated temperature greater than 101 Fahrenheit, which is equals to 38.3 Celsius. Severe malaise and toxic appearance. يكون الشخص تعبان جدا، يعني تشوف وضعيته هو جايك مبين عليه واحد تعبان ووضعيته خطرة. If the patient has any compromised host defense issues, like taking any medication, I just mentioned before, or having any uncontrolled diseases. Need for general anesthesia. When should I use it? Sometimes if you need to drain the pus. Okay. And if the patient needs a general anesthesia, like if he has a Ludwig's angina, which is a bilateral submandibular space infection involvement, or a deep facial space infections, requires treatment under general anesthesia. And or if you give the treatment for the previous infection but the patient did not comply with the treatment and there is nothing in progress، يعني عالجته وما فاد بيه العلاج، فكل هاي نحولها لأورال maxillofacial surgery. Okay, now principle 4 treatment. How you can treat the abscess. First of all, you have to remove the cause of infection by, before doing, like aspiration is not to remove the cause of infection, but I will do aspirate for every infection just to double check if it's a pus or something else, and send a sample to the lab to test for to do the antibiotic sensitivity test on the culture. But the first step to remove the cause of infection is either by doing a root canal treatment. Sometimes the infected tooth and infected pulp will lead to the pus formation, but again, if it is still within the alveolar process, or extract the tooth. These are the main tooth treatment. But if we have an abscess, we need to do the incision and drainage to remove the bacteria from the site and reduce the pressure and to increase the flow rate to the infection site. By increasing the blood flow rate to the infection site, then we're gonna increase the washability of the blood to clean the area. After we're doing all of these, then we do give an antibiotic as a supplement to the control of infection. So giving antibiotic alone is not right. Okay, just keep in mind, giving antibiotic alone are not sufficient to treat the dentofacial infection. First of all, I have to remove the cause of infection, then I will give the medication. So why we do drainage? Removal of the accumulated pus and bacteria, decrease the load of bacteria and necrotic debris, and reduce the hydrostatic pressure at the area, which will increase the blood flow rate and increase the washability of the blood at the infection site, which brings more immunoglobulins and immune defense cells to the area of infection, and antibiotics also, which lead to a good recovery and a quick recovery. So we're still in the principle number 4, which is the principle of treatment. And again, you see here, this is an intraoral swelling or a vestibular swelling close to the lower molar teeth. So first of all, we have to sanitize or disinfect the incision site. Why? Because I don't want spread of bacteria to the other sites. So we ask the patient to rinse his mouth with the mouthwash. يعني يقول له يتمضمض بالمضمضة مع الأسنان لمدة 30 ثانية. هذا البروسيجر أفضل تسووه ويا كل شيء حتى بالإكستراكشن. Then we will stab the incision. We will go deep into the center of the pus. Then we do a blind dissection with the hemostat. We do just like to open the incision site, then we will see the pus is coming out. So here we have to use not irrigation, we have to use a suction to evacuate all the pus material, and this will help us to reduce the spread of infection to other sites or that prevent patient from swallow the pus. Once we do that, then we clean the area, okay, lets the pus comes out. Then we put the pinhole drainage, which is a rubber material inserted deeply inside and close to the infection foci or infection primary site. Then we stitch it with some sutures. So again, the idea here is not to let the incised tissue to heal rather than do a passageway for the drainage, because the pus comes out anyway, either from the drain itself or from the periphery of the drain. يعني مو معناه انه احنا هذا مو 100% راح نسوي له سيل لهذا المكان، فالبس راح يطلع من هاي المنطقة وهم يطلع من هاي المنطقة، بس الهدف انه انا ما اريد هذا المكان يصير بي complete healing بعدين البس ما يطلع عندي. So then prescribe medication. These are the two drugs that we give to our patients: analgesics and antibiotics. So when should I prescribe? How should I prescribe medication? This algorithm is by a Canadian Royal College of Dentistry. So they give this algorithm to the dentist at their clinic as a guideline to help them when to prescribe painkillers or analgesics. So mild, if the patient comes to you and asking with the mild to moderate pain, the first thing I start with is acetaminophen, paracetamol. Okay, if the patient start with 1 gram or 1000 milligram provides sufficient pain relief. If the patient has no response and say, oh, I still have the pain, okay, or from the beginning the patient comes to have a severe pain, I'm not going to start with acetaminophen. I'm going to start either with non-steroidal anti-inflammatory drugs اللي هي البروفين، خاصة إذا ما عنده contraindication. أما إذا عندي contraindications للnon-steroidal anti-inflammatory drugs كان يكون peptic ulcer، حساسية من دواء معين من عندهن، فراح نحول على نعطي more potent analgesics اللي هي راح نعطي نعطي كوداين. الكوداين هو نوع من انواع الناركوتكس، ويا الاسيتامينوفين اللي هو عندنا بالعراق يعني صراحه مجربه المراجعين اسمه الجسك، هذا كلش قوي ومسكن فعال. اوكي، او عندنا اذا هذا في حاله اذا عنده حساسيه من النون ستيرويدال او عنده فد مشكله ويا النون ستيرويدال، نعطيه اسيتامينوفين ويا الاوكسيكودون لو الكوداين اللي هو خلينا نقول الجسكس. اما اذا ما عنده مشاكل ويا نون ستيرويدال اقدر اعطي نون ستيرويدال وياها كوداين، او نعطي اسيتامينوفين ويا كوداين، بس بالنهايه لازم يكون المريض يخلص من الالم مالته. هذا يا ريت تنطون نظرة عليه، عندكم اي سؤال عليه اشرح لكم اياه بعد اكثر. So, and again we're still in when and how to prescribe medication. So indications for therapeutic use of antibiotic, like if we have an edema and the infection is still in the edema stage, so I don't have cellulitis, I don't have a pus, so there is no need to give antibiotic. Just treat the tooth, remove the pain, and if there is a minimal pus discharge, it's okay. I can just give him do the root canal or extraction. No need to give antibiotic. But if I have swelling extending beyond the alveolar process، هذا معناه انه احنا طلعنا صار extra oral، يعني مو vestibular صار extra oral، or cellulitis، trismus، lymphadenopathy. lymphadenopathy معناها انه الليمف نود تكون involved with the infection، temperature as I said, and severe pericoronitis or osteomyelitis, which is bone infection. Here I have to give an antibiotic. What are The best antibiotics available in dental field: number 1, penicillin; number 2, amoxicillin; then clindamycin and azithromycin. If the patient is allergic to these two, if allergic to penicillin, I'm gonna give him clindamycin or azithromycin. Metronidazole and moxifloxacin. The best combination is metronidazole and amoxicillin. And when we give antibiotic for these two medication, we should not extend 7 days. 7 days or maximum 10 days, no more. So ask the patient to take 1 tab or 1 cap, 3 caps a day for 7 days. So it's going to be maximum 21 capsules or 21 tabs, no more. اكو بعض الاطباء يقول لك اخذ 3 ايام مقطعه، هذا الشيء غلط. اوكي هي النتيجه راح تبين ب3 ايام، بس انا حتى لا تصير عنده بكتيريا ريزيستنس لازم اخليه يخلص الشريط مالته، خاصه بالاموكسيسيلين والميترونيدازول. الازيثرومايسين والكليندامايسين 3 days gonna be okay because we're not gonna have an overdose. بس الشيء الغلط اللي عندنا، يعني اللي دي يصير عندنا مثلا نكتب له ابو 500 كبسول اموكسيسيلين ابو 500 يقول له 3 ايام وتقطعه، هذا الشيء جدا غلط. ابو 500 ياخذ خلينا نقول 2 منه باليوم لمدة أسبوع، أبو 250 3 مرات باليوم لمدة أسبوع، وأنت تقرر severity of infection. وإن شاء الله إذا بقى عندنا وقت أسوي لكم محاضرة عن drug prescription بس نخلص المنهج إن شاء الله، يعني محاضرة إضافية مطلوبة منكم بالامتحان. Situation in which use of antibiotics is not necessarily. يجي مريض يقول لك أوكي تكتب لي antibiotic، طبعا للأسف إحنا نسويها بس حتى نخلص من المريض. severe pain، هاي كارثة. أغلب الأطباء يجي المريض عنده ألم بدون ما يفحص، بدون ما يكتب له انتبايوتيك. يا أخي اكتب له انالجيسيك، اكتب له باراسيتول، اكتب له بروفين. هو أنت جاي لك على بين أو تفحصه، إذا ما عنده باس ليش تعطيه انتبايوتيك؟ أوكي. Periapical abscess, as I said, the swelling is still within the alveolar process. Okay, it's not extending beyond that. مشكلة اللخة dry socket. Dry socket, guys, never ever use antibiotic to dry socket. Dry socket is not an infection. It's something happened for no reason. Okay, so the management of a dry socket is not giving antibiotic, is just do a thorough cleaning for the area, mouthwash, and give a painkiller. اعطي باراسيتول، اعطي بروفين بس حتى تخلص من الألم. Antibiotic ما يحتاج. And multiple dental extractions in patient who is not immunocompromised، يعني واحد سوى له multiple extraction صحته زينة ما يحتاج أعطيه. mild pericoronitis، and again mild pericoronitis يعني بس المنطقة الجنجفة اللي above the third molar هي صار بها inflammation. The patient does not have any limited mouth opening, does not have any swelling, does not have any lymphadenopathy or fever. ما أعطيك. and drained alveolar abscess، أنا سويت له درينج وخلص بعد ما أرجع أعطيك، خلصت من الابسس. الانتيبايوتيك دائما مثل ما قلنا ذني أحسن 4 موجودات. هذني بالsimple odontogenic infections، بالسيفير أو الكومبلكس اللي راح بدي بسبيسز همات. amoxicillin with clovanic acid هي الأوغمنتين احنا نسميه، ويا أزيثرومايسين أو تتراسايكلين نقدر نعطي. And now we're gonna move to the new lecture which is the spread of infection. So احنا قلنا هسه قبل شوي جينا نحكي قلنا an infection gonna be stay within the alveolar process which is mild, easy to manage, but in case if we have the infection is spread beyond the alveolar process. So here are the classification of fascial spaces. Fascial, not facial. Fascial spaces معناها الفاشيا not face mean fascia. Fascia is like خلينا نقول نجيب الكلمة بالعربي مثل الكيس النايلون اللي يغلف المسلز. Okay, all these spaces are potential spaces. What do you mean by potential spaces? Which means these spaces does not exist or enlarge until we have a pus accumulation inside it or cellulitis. يعني هي ما موجودة بس في حالة من يصير عندنا انفكشن من حيجمع الباس، هي راح تصير قبل مثل خلينا نقول التشيز اللي راح ينترس به الباس أو السيلولايتس. So we can classify them based on the mode of involvement. It's going to be primary involvement or secondary involvement spaces. So primary, what do you mean by primary? That they have a direct connection with the infected tooth. Like we have a canine, fossa, buccal, and infratemporal. So the canine, most common teeth to cause a canine fossa abscess is the canine teeth and the premolars, the buccal, and again the posterior molar teeth, and infratemporal, the upper third molar. And we have a labial, which it will cause the infection to the upper lip. Labial infection is caused by infection of the upper teeth. And palatal, which is going to go to the palatal side. First, primary mandibular spaces, we have a submental, and again it's from the anterior teeth, submandibular from the premolars and posterior teeth, sublingual, and again it's from the premolar and molar teeth, and the buccal from the posterior from the molar teeth. The secondary facial spaces, this could be due to the infection happen to these sides and lead to the involvement of this spaces, except the masseteric and lateral pharyngeal and parotid spaces. These have also we can consider them are primary involved spaces due to infection of third molars. So the deep facial spaces, to make things easy for you, we have to memorize some muscles which will give us the boundaries of each space. Here we have the masseter muscles. Here we have the medial pterygoid muscles. Here is the mylohyoid muscle, and on the top of that we have the lateral pterygoid muscle, and here we have the superior constrictor muscle and the buccinator muscle. So that comes from the buccinator muscles. We have something called the buccal space. So the buccal space, it's confined to the cheek area. So it's follow the superficial surface of the buccinator muscles and bounded externally by the skin and fascia. هذا عندنا skin مع face, and medially from the buccinator muscle. Okay, and distally extends up to the anterior border of the masseter muscle. Submasseteric space and pterygomandibular and parapharyngeal and parotid, all of these spaces we can call it the masticatory spaces. We're gonna have that in detail later on. Okay, so and again let's go to the what we call the pterygomandibular space. Again, it's confined between a bone and a muscle. The bone laterally located, which is the ramus of the mandible, and the medial pterygoid muscle, which is located medially to the space. So pus will accumulate in this area, and it's easy to say it is because of the spread from the lower third molar to this area. So third molar infection could go on this way, could go on this way, could go on this way, and this way, or this way. And again, we have the masseteric or submasseteric space, which is again confined between a bone and a muscle, but here we have the bone medially and the masseteric muscle laterally, and we have a parotid space which is confined between the bone, gland, and muscles, two muscles. So this area is the parotid space. So as far let's say the difficulty of treatment and the severity of the infection increases if we go backward. So if you have infection or pus here, it's going to be easy to manage, rather than it's going to be here, rather it's going to be here or here. So the more we go deeply and backward or posteriorly, the more the severity and the more the difficulty in the management, and the more it's going to be the life-threatening condition. Okay. And again, here, this is the masticator spaces. What are the masticator spaces? Here we have the superficial temporal, submastocytic space, pterygomandibular space, deep temporal space, and infratemporal space. So, and again, this is the masseter muscle. We have to remember these muscles. We have the ramus of the mandible. We have the temporalis muscle here, and the lateral pterygoid and medial pterygoid. And here we have the fascia and the skin of the temporal area. هذين المصل نتذكرهن حتى تصير الأمور سهلة علينا. بالنسبة للباوندريز أنا ما راح أسألكم in details عليها بس بدكم تحفظون هاي الصورة وتتذكروها. Okay. Okay. So we discussed the submasseteric space or masseteric space. We said it's going to be confined between the masseter muscle laterally and the ramus of the mandible medially. But superiorly to this space, we have the what we call the temporal space, okay, which is a superficial temporal space, okay, is going to be confined medially. This is the temporalis muscle, and this is the tendon of the muscles attached to the ramus or the coronary process. And here is the fascia or the skin of the temporal area. So the pus is going to accumulate here. Here we have the deep temporal or infratemporal space, and again it's confined between a bone, which is the skull or the sphenoid bone of the skull. Inferiorly we have the lateral pterygoid muscles, and laterally we have the temporalis muscle. In this space and this space and this space, we're gonna have a pain and limited mouth opening, because the masseter muscle is responsible and temporalis muscle is responsible for the opening and closing of the mouth. So we're going to have a limited mouth opening. Here, we're going to have a pain and difficulty in mouth opening too. But for this side, which is the pterygomandibular space, okay, we're going to have a difficulty in swallowing and sometimes breathing. So again, this is a clinical image of the patients with a unilateral. Let's give you now how let's assess the patient at this stage. Let's pretend that this patient comes to your clinic asking for treatment, and I ask you I will ask you describe the lesion, describe what you are seeing. You're gonna tell me this patient, let's say it's a young male in his 30s of his age, having mandibular left side swelling. Okay, the swelling is almost with it's not a cellulitis actually, it's with confined borders. نقدر نميزه انه هو ما عابر على الفيس، يعني عنده borders معينة. Okay, with a with the redness of the skin over the swelled area. بعدين تعطيني الهيستوري مالته ايش قد صار له. Again, here we have for the submandibular and sublingual space infection, we have the mylohyoid muscle is the reference line. مثل ما قلنا المحاضرة السابقة انه اذا الباس عبر من جوا الاوريجن مال mylohyoid muscle راح يصير عندي submandibular space infection، اذا من فوقه راح يصير عندي sublingual. طبعا السبلينجوال مانجمنت مالته اسهل من السبمانديبولار. Okay, the best way to manage the submandibular is do the skin incision from this side. But again, we have to take care of the facial artery. Here we have in this area when do the incision. Lingually, it's easy, but we have to take care of the sublingual and submandibular salivary gland ducts and the lingual nerve from this side. Okay, but again, there's something special about the submandibular and sublingual. If this happened unilaterally, it's okay, it's manageable. The patient's gonna suffer, in addition to the pain, is gonna suffer difficulty in swallowing. بس مو limited mouth opening، يقدر يفتح حلقة، بس difficulty in swallowing. But if it's bilateral, then it's gonna be a life-threatening condition. We will call it Ludwig's angina. So this one is a bilateral submandibular space infection involvement, need immediate referral to the hospital. And the first thing we do to have such a patient in the hospital, you have to check the airway management. If it's bilateral, then it's going to affect the patient's ability to breathe normally. So before do any intraoral incision or drainage, check the airway patency and do the airway management, even give him intubation, then refer it to the GA ward and do the surgery for him under GA. And again, this is an example of buccal space infection. This is on the right side, and this is the submental space infection. So let's go to the buccal space, sorry, this is not buccal, this is canine fossa. Let's go to the canine fossa involvement. So the easy way to differentiate this canine fossa involvement from the buccal space infection is the disappearance of the nasolabial fold. If you compare this side with this side, you have a fold here extending from the ala of the nose to the commissure of the lip, which is called a nasolabial fold. حتى نقرب لكم الصورة اللي هم يسموها بالخطوط الضاحكة هسه، خاصة الفيميل patients من راح يضربون فيلر يقول لك هاي ما عندها تبين عندي، هذا يسموه nasolabial fold اللي هو نهاية البوكسينيتور muscles insertion ويا upper lip muscle insertion. اوكي سو هذا النيزولابيال فولد بالبكل او بالكناين فوسا انفولفمنت راح يختفي عندنا. هاي النقطة الأولى. النقطة الثانية راح تكون كلش قريبة من العين very close to the eye, and if we don't treat it immediately we're gonna have a problem with the eyes, and the infection gonna spread via the transverse vein here on the saddle of the nose and go to the cause a deep cause a thrombosis infection of the brain ويموت. وأعرف مريض مات بسبب هاي الحالة ما تلاحقوا له خلال 24 ساعة توفى، شاب عمره 23 سنة. وبالمناسبة هاي الحالات احنا معالجيها من تدرس بجلاسكو في بريطانيا. فلذلك أغلب الحالات أشوفها بالصور صراحة طلعتها من الكتاب اللي عندي وش اسمه حتى يعني شلون أقدر أشرح لكم عليه هنا. أنا أصلا معالجها لهاي الحالات. submental, this patient has a problem with the lower anterior teeth, but again the submental it's not that urgent or like severe infection, it's easy to manage. The reason why I put this picture, I'm going to show you the redness of the cellulitis. شوفوا الحمار اللي صار على المنطقة. اوكي الانفكشن يعني بهذا الحالة كان واصل عبر مرحلة السيلولايتس بعد يصير عنده باس بس بعد قريب اكثر على السيلولايتس، يعني هذا كان بعد اسبوع من الانفكشن هيك عندنا. Okay, and again this one if we want to do a drainage we're going to do extraoral drainage here from this side and after removing the accused tooth. So this is the buccal space infection and this is the submasseteric space infection. So as you can see, although we have في واحد يقول لك اوكي هذا شنو الفرق عن الكناين فوسا، راح اجي اقول لك النيزولابيال فولد بعدها مبينه عندنا. هذا واحد. اثنين مواصل للعين. ثلاثة تكون the distal border of the buccal space infection is with the located anteriorly to the masseter muscle والtemporalis muscle. المسيتر عندي هنا تكون والtemporalis نازلة منه، فالbuccal space حيكون anteriorly to the temporalis and masseter muscles. اوكي بالاضافة البيشنت يعني راح تكون وضعيته انه يقدر يفتح حلقة. اوكي but the submasseteric space infection, as you can see, it's more distally located. The patient has a limited mouth opening or a trismus, and the cause of infection mostly this one is the molar teeth, upper or lower, but for the submasseteric it's mainly the third molars, lower third molars. And if we see here, this is the axial section of the submasseteric space infection. You see here, this is the right side of the patient. This is the ramus of the mandible. هاي عندنا الماسيتر muscles. هذا البلس هنا متجمع بهاي المنطقة. هذا تشوفون البكل space infection للأسف ما عندنا CT scan لهذا البيشنت بس راح تكون بهاي المنطقة. more anterior. بهاي المنطقة راح تكون هذا البكل space infection. راح تكون هنا عندنا. هنا عندنا pterygomandibular. اوكي and السبماسيتريك another space infection. شوف الفرق بين ليش حطيت صورتين. هذا قلنا التريجومانديبولار والسبماسيتريك سبيس انفكشن هي مجرد مكانين بس اثنيناتهن عندنا muscle وبون. Confine the borders. The bone is the ramus of the mandible. If it's located medially to the ramus, then it's going to be pterygomandibular. If it's located externally or laterally to the ramus, it's going to be the submasseteric space. هاي المسيتر muscles, هذا submasseteric space involvement. هاي medial pterygoid muscle. هنا عندنا هنا in this case in the submasseteric, how we can differentiate it. The other point after X-ray, how to differentiate between the submasseteric and retropharyngeal space is in the submasseteric, the patient has a trismus or limited mouth opening. In pterygomandibular, the patient has difficulty in breathing and swallowing because it's more medial. Which one is easy to manage? Of course, the submasseteric. This one, I'm not going to tell you guys to do it by yourself. It should be referred to the ENT. Submasseteric, yes, you can do it because it's almost superficial. اوكي يعني راح تخترعون من هذا الجدول، تشوفوا طويل بس يعني الشغلات اللي نركز عليها بيه والله هو كله مهم صراحة. يعني هذا ملخص المحاضرة اللي حكيناه، كل سبيس، البوسيبل كوز منين يجي، من ويتش توث، الكونتنتس مالته، شنو الشغلات المهمة بيه، فذلك هذا ليش حتى تفيدني من اسوي درينج، لا اسوي دامج للستراكشر. اخطر واحد عندنا الباروتيد، باروتيد سبيس اللي بيه فيشل نيرف، خاف من عنده. اوكي و neighboring spaces البوز، يعني ليش نختار neighboring spaces؟ لان احتمال البرايمري سبيس راح يكون البكل، بس السكندري انفولفمنت راح يكون انفرا اوربيتال وتوريكومانديبولار. اوكي الانفرا تمبورال يطي على البكل. اوكي فهذا الجدول يعني رجاء تقروه، واذا عندكم اي استفسار او اي سؤال عليه تسالوني، بس هو ملخص للمحاضرة بالكامل. So reach the final slide, which is the summary of management. First of all, we have to determine the severity. As I said, it's going to be mild, moderate to severe. The more posterior and deeper the space involvement is, the more the severe the case. And if the patient has a tachycardia, tachypnea, fever, then it's a case going to be severe to manage. We have to refer to the oral maxillofacial surgeon. Evaluate the host defenses. Determine the setting of care. يعني هل يحتاج general anesthesia لو ما يحتاج، أقدر أسوي بالعيادة لو ما أقدر لازم أحوله مستشفى. Treat surgically, support medically, and choose and prescribe appropriate antibiotics. So أتمنى إن شاء الله تكون وصلتكم المعلومة بشكل مبسط، وإذا عندكم أي سؤال اسألوني على الجروب. مع السلامة.